All right, everyone,
Matteo.
maybe we will get started. People will probably continue to join as we go on. Hello, everybody. My name is Nicole Cork. I'm the Association Manager of iHEA's activities. Welcome and thank you for registering for today's webinar, How Are Countries Mobilizing and Protecting the Health Workforce in Response to COVID-19, hosted by the Health Workforce Special Interest Group. Today's webinar will run for approximately 60 minutes, and we are recording it, and it will be uploaded online afterwards. Before we begin, I just wanted to run through a couple of housekeeping items. If you do experience any technical issues during the webinar, please use the chat box at the bottom of your screen, and I'll be happy to assist. Everyone on the line has been muted except for the speakers in an effort to eliminate background noise. So if you have any questions during the webinar, please use the chat box and they'll be addressed by the speakers. I'm now going to pass it over to today's moderator, Bianca Frogner, to introduce today's speakers.
Thank you so much, Nicole, and thank you to everybody joining us from around the world. I know we have folks all the way from Australia, and then there's some of us here in the US, and so there's a huge time zone difference across all of our participants. So I appreciate everyone's participation, including our speakers. And we have some wonderful speakers here today. You do see one of them driving there, so hopefully he gets safely to his place. So I do hear just a little bit of background noise, and I think it may be coming from Matteo, our speaker, so I'm just going to ask him to just mute himself for now until I ask him some questions. So thank you so much, Matteo. And as Nicole said, along the way, if anyone has any questions, please put them in the chat box, and we'll do our best to monitor those questions. I see that some of our participants are joining us by video, and we welcome that. Just as long as people can keep their themselves muted, that's great. And along the way, we'll do a combination of questions via chat, as well as people are welcome to ask, verbally too. But to kick us off, we have three excellent speakers, and hopefully maybe our fourth one may be able to join. This is a unprecedented time, so people have many obligations, as we know, as many of you on the phone are here on Zoom, as well as our speakers are being called upon as experts in the field to address various dimensions of COVID-19. So I know everyone's very busy. So again, thank you for taking this time. I want to introduce our speakers. We have Michelle Isaac. Dr. McIsaac is an economist and a health workforce specialist who works with the World Health Organization. She has her PhD in economics from the University of Melbourne and has held academic positions across the globe, including Canada and Australia, Germany, and the Netherlands. She brings perspective on health and labor with a focus on gender and equity issues around the world. So we're really glad to have her here this morning. Next, we have Dr. Joanne Spets. She is recently was given a new appointment, which we're really excited about here in the U.S. She's the inaugural Brenda and Jeffrey L. Kang Presidential Chair in Healthcare Finance. And she's the Associate Director for Research at the Philip R. Lee Institute for Health Policy Studies at the University of California, San Francisco. She also directs one of our health workforce research centers here on long-term care, funded by our federal government. So she's definitely an expert around a number of healthcare issues, but particularly around long-term care. We have Dr. Matteo Mcgarry, who's a professor of political economy in radiology, diagnostic imaging, and radiotherapy techniques degree. He is the one driving right now, and hopefully will safely get to his spot. We really appreciate his making this work. He is a health economist whose areas of expertise has been around decision modeling for evaluation of healthcare programs, pharmacoeconomics, health policy, and emergency management. So we have perspectives here, a global perspective on our panel. with some particular experts on the U.S. and Italy. And so again, and I know we have many people on the phone from around the world, and I'd love to see in the chat box if people, as we're getting going here, just to see what countries you're all from. So as just to get a sense of kind of the variety of perspectives we have in the room, because I'm sure many of you have thoughts around our health workforce. So we do welcome you all as part of the conversation. So today we're going to be talking about how our countries are mobilizing and protecting the health workforce in response to COVID-19. As many of you know, COVID has claimed the lives of thousands, if not millions, in many countries around the world. And we're realizing that our health workforce is really critical at this juncture because they are the ones on the front lines caring for our COVID patients. And, you know, the health workforce is broad. Oftentimes it's the doctors and nurses that probably we hear the most about in the news or haven't been aware about, you know, before COVID. But I think this pandemic has really shined a light on the broad number of people who work in healthcare who play an important role, including people like respiratory therapists who are helping us run those ventilators that are so critical to care for our patients. And a lot of people prior to this might have heard of a respiratory therapist before, but now people are probably more familiar with who they are than ever before. We have our emergency responders who many of us, you know, we're also aware of, who respond to our emergency calls, but they are the ones who are actively on the ground these days, finding our COVID patients, managing them at the first point of care, figuring out where next to bring them. And then we have many other support workers who help keep our elderly safe and sound in nursing homes, in the home, in hopes to prevent our elderly from having to go to a hospital when going to a hospital right now is quite unsafe in many parts of our world because it puts them at higher risk for infection of COVID. So we're trying to keep people safe at home. So we're realizing there's many different kinds of people that are critical, but the hardest part is figuring out how do we use our healthcare workforce effectively to manage the crisis. And so what we're hoping today is to get the perspectives of our esteemed panelists. And I'll be doing kind of a round robin style, asking the panelists a set of questions. There's no slides being presented here. It's really just a discussion that we're hoping to have today. And things are quickly changing, so we also recognize what we say today could change tomorrow. What we would have said a month ago is probably very different than what we're about to say today. So we recognize that this is a very dynamic process right now. So that being said, I'd love to just kick it off and kind of get a sense of kind of what's happening around the world. And I think I'm going to start off with Michelle, given her role at the WHO, and ask her to give us a sense of what you're seeing from the WHO's perspective of how countries are mobilizing their workforce. Give us a high-level perspective of how's it going? What are you seeing? Which countries are you seeing emerging as leaders? You know, as exemplars of how they're best mobilizing their health workforce? It's a big question, but
it's a big question. So I think the way to sort of frame what we're seeing a lot is I have colleagues from all over the globe. Some of them are not native English speakers, and I've had a few people call me up and ask me, what does surge mean? What is this word surge? I've never heard surge before. We're hearing surge capacity. We're hearing surge modeling. We're hearing surge everything. What is surge? So I think for us, what we're hearing a lot from countries is this immediate need to upend and to contribute really to the health workforce and what we're seeing. So the WHO for a while now has been talking about this global shortage projected 18 million workforce shortage by 2030. So for a while now, we've been saying, look, we're running out, especially in terms of we're looking at distribution of health workers across the globe. We have certain areas that just have a very large lack of health workers. And when we talk about health workers, we talk about all health workers. So that's doctors, nurses, midwives, respiratory therapists, community health workers, traditional healers. We're really talking about the full gamut of health workers. And so we're counting up the health workers and we're saying we have a pre-existing health workforce shortage. And in many countries, we're working proactively to address this health workforce shortage that they're dealing with before COVID-19 arrived. And this is sometimes always what we found is attributed to the supply side issue. So we're saying there's not enough health workers and we need to produce more health workers. But what we've been trying to really push with countries in the last few years now really is to say this is also a demand side issue. So what we have in lots of countries is that there are simultaneously very high vacancy rates. I see some colleagues who are on the line from some countries I work in where I know that there are 90% vacancy rates for some cadres or some occupations, and simultaneous to this you have unemployed health workers. So you have workers that can't find jobs. So there's this kind of matching that's not sort of happening. And so we've been working with countries pre-existing before COVID to try and think about how do we match numbers, how do we match across geographic need, and how do we match skill sets. So what we're finding now as COVID sort of emerges is that there's kind of an acute knowledge of this kind of skills gap, right? So we're seeing that there's a particular specialist gap that's emerging in a lot of settings. So we know that we need specialists who can treat severely ill ICU patients in particular settings. And then we've seen a quick demand increase for this kind of health worker. And then countries grappling really quickly to see how they can kind of meet these needs in these particular areas. Testing is another area that we're seeing, a need for surge capacity. And there's a lot of kind of frontline health workers testing out on the front lines, but also the laboratory testing. We need this surge capacity in these areas. So countries are really grappling with the concept around these surge needs, as it might be. And then this really means that they're kind of facing this skills matching that they're looking to be doing, but then also this kind of geographic matching. And what we've seen prior to COVID-19 is that there's a distribution issue often across countries and within countries of health workers. And now you're seeing that with kind of a new lens, which is like there's these hot spots for the outbreak. And then how do we kind of address these hot spots and get health workers to where they're needed in this kind of acute setting? So this is something else we've seen a lot. And I think
Great.
the thing that's really interesting is the countries' focus on skills as well. So we've seen a lot of countries be really focused on how do they get the skills of the health workers to match the particular setting that we're in. So those are some of the things that we're seeing.
Great. Thank you, Michelle. That was a great overview of some key topics we hope to dive into a little bit more as we go on with the discussion. But thank you for that fantastic kind of review of all the major issues that we're also seeing here in the U.S. And from that, I'm going to transition to Joanne and ask her to give a perspective on how we're thinking about health workforce planning here in the U.S., especially kind of thinking a little bit about some of our distribution issues. We know that COVID is affecting our urban areas a little harder than our rural areas. So maybe, Joanne, could you give us a little bit of a perspective of what's happening here in the U.S. as we think about the health workforce? Again, kind of keeping it at a high level right now, and we'll dig into some issues, but maybe focusing a little bit on the challenges of urban versus rural.
Sure. We have a similar situation as Michelle described, that within the United States, there is a lot of variation in the availability of health workers. And typically, as in most countries, rural communities have fewer health workers available to them, and then urban areas are more likely to have enough supply, although that varies a lot across the different urban areas of the United States. And then we also are having the hotspot phenomenon, where the need is varying across different communities and cities. I would say the United States is not, even though it is a single country, it does not tend to approach workforce planning as a single country. It's all largely at the level of the states. And so one could liken it to the EU, where if every state of the United States was a separate country of the EU, each of which has its own regulations, its own healthcare infrastructure, its own policies. And then of course we have a heavily privatized system, so that the planning, while the states can provide guidance or make recommendations around planning and have under emergency authority the ability to quickly adjust some regulations to support the workforce surge that they might need, they also are very heavily reliant on the private sector for action. So in California, and I think New York, which has been our most severely affected city, very similar things are happening where private hospitals, they are not government-owned hospitals, are asked or expected or forced by patients coming in their door to rapidly expand their capacity. And so there is no government direction on a lot of that. A lot of it is happening through those private hospitals, individually trying to find enough physicians, nurses, and other providers. And at the same time, in many of our states where we have very good state level government, the state government is coordinating with those hospitals to try to rapidly recruit or identify workers and support additional expansion of capacity. So in California, for example, where we have not yet been affected to the degree of other states, our governor has been working with the local communities very actively to reopen hospitals that recently closed, and at the same time to encourage or put some pressure on private hospitals to also expand their beds. In the case of the institution I'm in, which is a state university system, but still largely financed through private insurance, we reopened a hospital that had not long ago been turned into only outpatient facility. And we have reopened that to be only COVID for non-intensive care COVID. So we've got this weird mixture, and every state's responding differently. I think some states are largely ignoring the situation, and some rural communities have been impacted, especially where we have had processing plants for meat products. Rural hospitals in those communities have been overwhelmed. But those are hospitals that already were short on finances, short on supply of workers, and it doesn't take much to overwhelm a rural hospital. So we've got this very interesting mix, very akin to what Michelle described.
Great, thank you, Joanne. That was very helpful perspective. And you know, I see that Matteo may be just about settled into his more permanent location here for this presentation. And maybe just, I'll give him a moment to settle in. And I realized real quick, I did not introduce myself. I'm Bianca Frogner. I'm a professor at University of Washington in Seattle. And I direct the Center for Health Workforce Studies. So I also, you know, bring a U.S. view and, you know, can confirm many of what Joanne is saying of, you know, the challenges of each of our states acting very differently. And well, I would like to, you know, keep our conversations kind of focused at a national level, and, you know, recognizing that within each country, we have much variation within it. And I can say from here being in Washington State that how we act as a state is very different than how other parts of our country is operating. So,
and Joanne,
and a lot of our workforce planning. Yeah.
If I might,
go ahead.
I'm just wondering, when you're talking about the private sector, public sector, have you seen with the COVID-19 outbreak any movement of health workers from the private sector into response in the public sector? Or are they very much staying kind of parallel?
Oh, that is an excellent question. I don't know that we have enough data to say for sure. I think private hospitals and public hospitals are largely taking equal brunt of this so far. New York City, for example, has a number of private hospitals as well as some large public hospitals, and they've all been impacted very heavily. So I don't know that there's a lot of differential. What we are seeing is that hospitals that are more financially unstable or already had financial problems have been furloughing workers if they do not have a surge. And the challenge for them is that patients have not been wanting to go to hospitals because they're afraid of infection. And hospitals have been directed to postpone elective procedures. So you also have people not going for knee replacements and the normal kinds of things that you could schedule. So for hospitals, in the United States, our hospitals are very dependent on procedures for their financing. Most of them do not have a global budget. And so when they delay or defer these elective procedures, they no longer have money and they don't have need for workers. So we have simultaneously workers being furloughed while we have surges occurring in other places. And because each state licenses its own nurses separately, if the state has not established an emergency provision allowing workers from other states to automatically come and practice, then workers can't move. Now, most states have issued those regulations to allow workers to move across states freely, but not every state has done that yet. And that could be a barrier for states that don't enact those kinds of rules rapidly. But New York did, and they've needed to. So for New York, if a nurse, for example, is furloughed in South Carolina, that nurse could go to New York City and practice there. But then there is no real centralized system to identifying which hospitals would need that nurse the most and how to get that nurse to that specific hospital. So hospitals may be competing against each other, trying to find workers in the United States. There really is not that centralized coordination that one might hope for in this kind of emergency situation.
Great. So let me see, Matteo, I would love to bring you into the conversation. Are you able to hear us now? I think you're on mute, so if you want to take yourself off mute. Just give him a moment. There we go. There we go. Hi, Matteo. Great. Thank you for joining us. You're a little quiet. If there's some way we can get your volume up, that would be great.
Just connecting. Okay.
It's a little bit better. Yeah. Yes.
Can you hear me now?
So, yes. If you can speak a little louder, that would be helpful. But we can hear you. So I would love to get your perspective, Matteo, given that Italy was really kind of front and center in the news as one of our first countries outside of China to really see a surge in COVID patients. I'd love to hear your perspective on how workforce mobilization evolved from the start of where when COVID first started to arise versus kind of where things are now. Can you give us a high-level perspective on what has been going on with the health workforce, what strategies are emerging as effective ways to care for COVID patients?
Right. Actually, the situation is quite improving in Italy. If we look at the total of the infected as diagnosed without considering the the asymptomatic one, we are approximately on 100,000 people that got infected, and we have 25,000 deaths. Of course, there is a huge variation between areas. The northern part of Italy, which is the red zone, we have finished the total lockdown since Monday. Now things are improving, but of course there are still risks of a second spread of the pandemics. How about the health workforce? Just to give two numbers, actually, we have 22,000 health professionals that have been diagnosed with COVID, so they have been infected, and about 200 have died. A huge part of these deaths were in the first stage of the pandemics, so up to 10 April, we had sort of 150 health professionals deaths. The 75% more or less of deaths and also of the infected are the medical doctors. The setting, the setting that experienced more infections was the hospital one, of course. And also we had a high number of general practitioners that were infected. Because at this beginning of the pandemics, there were at least 3 different pathways of diagnosis. The first one was going to the general practitioners because of symptoms. The second pathway was going to the emergency rescue, and the third one was going to an ambulatorial setting. Of course, the most dangerous one, the one that made the pandemics spread, was the emergency rescue setting, because we were not prepared to such crisis, to afford such a crisis, so that practitioners and the health workforce in general didn't follow specific, so disease-specific protocols and practices. For example, on the 21st of February, when there was the first official infected that underwent immediately intensive care, it was the third time that he was asking for help at the emergency rescue. So when he was very severe, at the end, he was admitted at the intensive treatment. But in this way, the practitioners and nurses followed non-infectious specific protocols. So this was one probably of the reasons that made the pandemic spread in that area. How are we reacting actually? The real big problem concerning the health workforce in Italy is that these pandemics came at a moment where we were experiencing, there's some noise.
Oh, looks like things, Matteo may have gotten stuck there. Yeah. It got interesting. So we were hearing him, but it sounds like he may have heard some background noise on his side.
Yes, because one of my sons is doing the lectures, classes online, so I think there was some
of course.
kind of interconnection. Can you hear me right now?
Sure, no. Yes, we can. Yes.
Okay, perfect. So I was saying that these pandemics came in a moment where we're experiencing in Italy a huge shortage of healthcare professionals in general. Just to give you an example, some months ago, because of these shortages, some regions in Italy asked medical doctors that were in pension and also military medical doctors to go to hospitals to help the health professionals in service at the hospital. And another problem, especially in the residential settings for elderly, is that most of the staff has not a permanent full-time position. They are hired by other organizations, and so that each healthcare professional has not his or her own specific unit or department. He or she goes where he or she is needed. So we were experiencing a decrease in the quality of care in these settings. So the residential ones for elderly. This was another problem that was in favor of the spread of the contagion, especially in the northern part of Italy.
Matteo, you're cutting out a little bit. Could you, I'm sorry, you're cutting out a little bit. Could you speak a little bit more directly into a microphone?
Yes. Are you okay now?
Oh, there we go.
Can you hear me now?
Yes. Yes, that's good. Thank you.
Are you okay?
You're saying some important things. We want to make sure we
Yes.
capture you.
So,
you sound good now. Thank you.
Okay. The fact, the other important thing. The first thing that I think that we have to learn from the Italian perspective is that hospitals and in general healthcare services should not operate on the efficiency frontiers because of the high risk of experiencing some kind of emergency or extraordinary events. What we learned from the health economics handbooks first is that the health product, health outcome is by definition uncertain. So that if we operate on the efficiency frontiers, then we are taking a huge risk of something can go wrong, and this was the case. So what to do now? There are the second lessons, that we have to keep in mind is that probably in a universalistic setting, regionalism or federalism, when there are areas of a country or of a jurisdictions where there are huge inequalities, mind the gap between North and South, probably federalism is not the right solution. We have to think about a recentralization of the healthcare system if we want to think about a healthcare which is universalist. So what the other thing to do is to give much more importance to the primary care setting. There are some sort of experiments ongoing right now in some hospitals, especially in the northern part of Italy, that are experiencing telemedicine programs in order to treat and assist the COVID patients. And these telemedicine programs involve, of course, they are is a labor-intensive practice, and they involve nurses or, in other case, pharmacists. As Istituto Superiore di Sanità, we are looking at the first data of the Codogno Hospital, which was the first one to experience the outbreak of the pandemic. And we are observing that when patients access the telemedicine program from an ambulatorial setting instead of an emergency rescue, then there is a higher probability of not being hospitalized. And not being hospitalized probably represents the good solution for the health workforce as well.
Great. So Matteo, I'm going to stop you there because you're bringing up lots of great points. Thank you. I want to make sure that we get Michelle and Joanne's perspective here because you've brought up a number of very important issues. You know, Matteo brought up an issue about, you know, the fact that many of our healthcare workers are getting sick and they're dying also, and that getting them protection, especially personal protective equipment as well as testing, we know, at least it's been a challenge here in the U.S., and by trying to figure out how to get them that protection, we may reduce their risk, but supply chain is an issue. The affordability of the equipment is an issue. I'm curious from the WHO's perspective, you know, what are ways that countries can ensure the health of our own health workforce, so not to exacerbate a shortage issue that may already be being experienced in countries?
Yeah, so I think what we're hearing the most is really around the shortage of personal protective equipment to the places that it's needed the most. So these are the health and social workers who are interfacing, you know, on a day-to-day basis with cases, but also those who are supporting those health workers. And so we've heard a lot about the shortage. But the other thing that's important on top of the availability issue is around the training of the appropriate use of personal protective equipment as well, and to ensure that that personal protective equipment actually fits on those health workers that are using it. So I think that what WHO has been saying is availability and training on personal protective equipment. And then I think that we've also heard a little bit around the fit of this personal protective equipment to ensure that it actually fits so it can do what it's there to do. And then I think the other thing that's kind of missed in this talk, and it was a point raised a little bit earlier, I think by Joanne, around health information systems, is that there's an issue in many countries around the weak surveillance systems to kind of reinforce the safety practices that are implemented, and then the ability to quickly address any breaches that we see. So we not only need to provide the equipment, we need to train on how to use the equipment, ensure the equipment fits, and then follow it to ensure that it's doing what it should be doing. And if we have any outbreaks or any issues happening, that then we can know what to do to address them right away. So I think those are some of the things around PPE that I can bring up from the global perspective.
Great, thank you, Michelle. Joanne, maybe could you speak a little bit to some of the issues around surveillance, as Michelle kind of pointed to. Where does surveillance fit as it relates to our health workforce? Why is it important? Who are we trying to surveil? Could you speak a little bit to that?
Yeah, I think a lot of, again, there's variation across every state, but there is a recognition that health workers, both, we don't want to get them infected or to have them get sick because that is a hardship on them, their families, and so on. But also if they are sick, and particularly if they don't have symptoms, so we don't know if they're sick, they could also possibly infect their coworkers and their patients. So the surveillance is important on both sides. Now that the United States seems to have enough tests in most of the country, although it varies by state, we have seen a lot of hospitals create kind of routine testing approaches for their workers. Initially, most were focusing on workers with symptoms or who were known to have possibly been exposed. They might have had a failure of their equipment or some other issue. And now, fortunately, with more tests available, I know our health system can tell workers that if they can get a test, even if they have no symptoms. And we are seeing some data that suggests that at any given time, it's possibly up to half of people with the infection are not showing symptoms at any given time. So this is a real concern. The area where we have been very short on testing of workers is in our long-term care facilities, in our nursing homes and skilled nursing facilities, residential care. Those facilities have been ignored because the surge preparation has focused on hospitals, largely based on what we saw happen in Italy. And we have failed to think about the surveillance in the nursing home sector. So now many of the patients and workers who are infected are coming out of nursing homes, where the patients are older and more at risk of having severe morbidity and mortality from COVID-19. And their workers are considered essential workers and may not have the protective equipment or the testing that we would need to have to protect both the workers and the residents. Another part of that some of us are trying to get data on now is that because many of our long-term care workers are not paid very well, and the minimum wage in the United States is quite low compared to the cost of living, many long-term care workers have multiple jobs in order to support their families, which puts them at greater risk for exposure in different settings, and also increases the risk of them unintentionally transmitting COVID-19 to patients if they're working in multiple settings, or some might be working in a grocery store or in the food industry, and then also in long-term care, and maybe unintentionally serving as a vector for the disease because they are not paid a living wage. And we don't have the surveillance in place to really help prevent that from happening. And we don't have the systems in place to support those workers who are taking great risks in order to serve their patients.
Great, thank you, Joanne, for that perspective. So I noticed that Florence brought up the question about mental health. I mean, right now we just talked about the physical health of our health workforce as it relates to COVID, but this is definitely taking a mental toll on our healthcare workers as they're basically on a marathon run here of seeing patients every day with very complex health issues. And I'd be curious to hear from Matteo, given that Italy has been struggling with this for quite a while. What is being done to ensure that that our healthcare workers are not burning out? What is being done to ensure the mental health of our healthcare workers?
Not so much in reality. Just think about the fact that if we were experiencing shortages and therefore burnouts from healthcare professionals before this crisis, of course the level of burnout has increased. The thing that there are some sketches that I can tell you, as for example, healthcare professionals that for 15, 16 days did not stop working, just slept 3 or 4 hours without going home to recovery, because of course they didn't want to get in contact with their parents. So this was another factor that increased the burnout. I think that consequences, is too early to look at consequences, because I think it's something that we will see when this crisis will be over. But anyway, in my opinion, not in my opinion, sorry. In some organizations, in some hospitals, the hospital managers have tried and are trying actually to do a sort of rotations of healthcare professionals but this regards only nurses that can be employed in different, units. This is something very different for specialistics, for medical doctor and specialists. Another thing that some hospitals have done is to reduce the shifts of nurses and medical doctors. In an ordinary times, the typical shifts are one morning, afternoon, and night. In order to reduce also contacts, now the shifts are reduced. One daily shift is 12 hours from 7 a.m. to 7 p.m. And the other one, the day after, is the night shift from 7 p.m. to 7 a.m. so that health professionals has got 3 days off, and then they can start again. That's all actually about measures in order to reduce stress. It is not the first issue now in Italy, and probably is not right. This is not the right thing to do.
Great, thank you, Matteo. You bring up an interesting issue around shifts that makes me wonder about this question from one of our audience members about the role of unions. And maybe Joanne may be able to speak to this, given that unions are quite strong in some of our hospitals as well as in our long-term care environments. As we're trying to see health systems and healthcare settings try to be creative about managing our health workforce effectively, what kind of barriers are there in place that may make some of the changing of timing of people's schedules, as well as issues around their scope of practice? What kind of barriers may be in place, and are unions part of that picture? Are they helping? Are they hurting?
That's a great question. I think the labor unions in the United States are not equally strong everywhere. California, Washington, Massachusetts, and New York do have very active unions, particularly for nurses. In general, in the United States, physicians are not unionized. Most of what we have heard is concerns raised by the nursing unions about the availability of personal protective equipment and the overall safety of their work. But historically, some unions have also had negotiated very strict rules around scheduling, hiring practices, and other factors that may need to be negotiated if there are surge issues within those hospitals. California is the only state in the United States that has a fixed minimum nurse-to-patient staffing ratio. And the governor has stated that hospitals can apply for a waiver from that ratio. But at this point, I don't know if such a waiver has been issued. And there is a question, and since we have not had a major surge like Italy or New York, we have been okay. But we do wonder what will happen if there is a major surge and if our government can process those rapidly enough. And so
Great. Thank you, Joanne.
I predict, though, with the protective equipment, I predict that our unions across the United States may become more active, and nurses in places that are not unionized now may discuss it, recognizing that the availability of protective equipment has been very uneven. And this may motivate health professionals to unionize when they would not have otherwise.
Thank you, Joanne. So Michelle, I'd love to hear your perspective on issues around scope of practice in particular and the barriers that countries are facing and strategies that countries are using to better mobilize their healthcare workers. Because we know that, in many countries, we have fairly well-defined roles of what healthcare workers need to do. But as you brought up early on, there are skills gaps that exist that need to be filled by probably other workers. But so how are countries dealing with that tension? Is there tension that's consistently seen across countries to try to move healthcare workers into roles they may not have been doing traditionally otherwise? And what's working to try to get over those barriers?
Yeah, I'll get to that question, but first I just want to circle back to what Joanne and Matteo have been saying around working conditions and protection of health workers in general. And I think one of the things that that many of us aren't thinking about or that don't know is that in many countries around the world, there are health workers who aren't protected from the undue consequences of catching COVID-19. So there are many health workers who work in settings where they don't have any work protections or very little work protections in which they're having. And so if they do get it, they're not entitled to compensation or rehabilitation or even the curative services that they might need to deal with it. So it's putting a very high cost to some of these kind of frontline workers to actually going to work during this time. And we've had some countries come to us and tell us that they've been experiencing health workers who don't want to be working in settings where there's COVID and actually not wanting to go to work for these settings. And I think that's an important thing that we need to be thinking about, is how we're treating our health workers, not just in the sense of personal protective equipment, but in the sense of, you know, protecting them in the longer run if they do get infected. And then I think that links to the question around mental health and social psycho support that health workers we're not seeing very much about this coming up. And you have to imagine that there are going to be some longer term consequences to what health workers, you know, are dealing with and grappling with. And I think that's really important when we're talking about the safety and well-being of our health workers. When we're in a pandemic setting, we tend to look at the short term, but there are lots of long-term consequences. And we know that there's an implication for burnout if there's very high workloads, and that there's an implication for attrition if there's burnout. And so, you know, we have to be thinking in the longer run, if we've already been grappling with a shortage, we're going with this, and then we have two issues that can come up. One of them is that the health workers we have tend to not want to come to work or tend to leave this setting and find other occupations, but then also that the attractivity of the sector might be decreased. And that could have implications in the long run as we try to ensure that we're meeting the health needs of our populations, and I think this is where we as economists, you know, can kind of think about the balancing act of that and sort of its longer term consequences. In terms of scopes of practices, I think what we've seen is there's a lot of countries who are agile in this space. We've even seen, emerging scope of practice around COVID-19. We've seen lots in terms of surge training. WHO itself is launching an app, I think this week or next week, on training, and this app was made in response to health workers' questions. So what did they think that they needed to know about, and then to train them so that they could do that. That's happening kind of a more ad hoc, but I think also within each individual setting, we're seeing a lot of malleability and relaxing essentially of these kind of rigid lines, so that we're ensuring that we're meeting the needs. And I think we're seeing that fairly, I mean, that's one of the areas that I think we're seeing it's a little bit more fleshing than some of the others.
Great, thank you, Michelle. So I'm cognizant of time. I know this has been already a very rich discussion and we've just barely scratched the surface, but given that many of our audience members are health economists and probably researchers, and Michelle, you kind of touched on a particular topic that people could probably dig into more. I mean, what would be some suggestions of areas where we can mobilize our health economists, our researchers, to better help inform this discussion? This is a rapidly moving area right now. So what tips or advice would you give our audience members about how they can mobilize their own research expertise to help inform the discussion? So maybe, Michelle, I'll start again with you and just go down the line.
Yeah, I think one of the things that the projects that I can plug, I guess, here, that I've seen emerge from this is something from the, I think it's with the Canadian Health Workforce Network, which is Ivy Bourgeot and colleagues in Canada, and they're collating data on innovative responses. And so I think mid-May. So I think next week we'll start to see some of this evidence and data come out of what countries are doing, and that'll be published on their website. And I think that one of the things that also is really important is to be thinking about health systems resilience. So I think this is really picking up an important component for people who are interested in economics, health workforce, is around how do we ensure that countries, what can we learn from this to ensure that countries can build more resilient health systems in the long run.
Great. Joanne, any tips or advice, areas of focus that you'd like to see in future research or work?
Sure. First, I'm putting in the link, or at least I hope it's coming through, for the Canadian system. It's going to be very interesting to see that inventory. You know, I think that there are going to be some very fundamental questions, both in health financing and in health workforce dynamics. As Matteo noted, we have tended to organize our staffing in hospitals based on being very efficient and being, you know, at the boundary of the production possibility and so on, which gives you no slack for this kind of pandemic. And so I think there will be some fundamental questions related to the incentives that employers or hospitals in particular are given around staffing and how to create that slack in a way that is economically optimal. You know, so I think it's almost like think about your distributional problem over time rather than at a single point in time. I also think that the dynamics of the workforce will be very important. If labor supply is a function of the wages that can be earned as well as the other non-wage aspects of the job, if the job has become riskier, if the job has become more unstable because of furloughs in the midst of safety risks, then that may reduce the long-term supply to the profession at the given wage. But we don't really know how that's going to play out yet. And so I think that there is a real concern about young people who are thinking about the health professions, looking at the employment uncertainty and the personal safety risks and selecting against the health professions now when on the margin they might have previously. So I think this will require some research to understand. It may make it more difficult to address the problems that Michelle was describing at the very beginning of many regions of the world having a shortage of workers to begin with.
Great. And Matteo, any last ideas or advice for our audience members who may want to contribute to the research, body of research out here to help inform countries like your own?
Yes. I think that economists, health economists, should remember that the healthcare production has a function that is by definition stochastic. And this has, I think, a huge impact in the kind of previsional models that we use, especially when we go into simulations. This is the first thing. And probably the second thing is to also think about the macroeconomic, not think about, sorry, but inform decision makers also with possible implications coming from Keynesian macroeconomic theory, so that if you invest in labor and so in healthcare, in health workforce, in this specific case, then you can put on the Keynesian multiplicator. So give a potentially important impulse to consumption. And this should become particularly important as at a global level, we are going to experience a quite long period of economic recession. So probably a way to support this crisis is to invest in health professionals, new health professionals, so very young people, so that they can start thinking about a family, buying a house, and increase consumption levels. And we start also thinking about how to win our challenge against the big economic crisis that is upcoming.
Thank you, Matteo. That's very
and
great.
I want to chime in because
yeah,
I think
it's
perfect thing that we have from the beginning to the end, which is we need to think more about the demand side. And I think that's what Matteo was just saying there. And I think it's what we sort of started at the beginning. And I think that's one thing that you really notice in this area of work is there's lots of effort, lots of people looking at the supply side and very little on the demand side. So that's really something that we really need to bolster.
Thank you, Michelle. Well, I really appreciate everyone's contributions on this panel, as well as I saw some good back and forth there in the chat. We're lucky to have such a global community here through iHEA, and I want to thank iHEA for giving us an opportunity to have this very important panel. I hope it was informative to our audience members, and I want to give a big thank you to our panelists for taking the time out of their busy day to do this discussion. And again, we just scratched the surface. I'm sure many of our panelists are happy to keep the discussions going offline. And you know, I know travel to future conferences may not be something that many people want to do in the near future, but I do hope that we find ways to keep these dialogues going in other alternative means, whether it be online, through emails, other future webinars and things like that. So if others have interesting ideas for future panels that people want to see discussed, the Health Workforce Special Interest Group, I think, is open to entertaining those ideas. So thank you so much, everybody, and I hope you have a great day or great night, depending on where you are in the world. So thank you again.
Thank you, everyone.
Thank you, Michelle. Thank you, Joanne. Thank you, Matteo.
And it was a big pleasure.